hope more folks will come trickling in. We've got a lot to cover, so we're going to go ahead and get started. I'm Rebecca Lieb. I'm a clinical psychologist in neurobehavioral health. So I'm going to get things going and talk about autism spectrum disorder and just kind of help you get a little bit of an overview on some of the changes to the DSM, what we think about when we talk about autism spectrum or ASD now, how we assess for it, and then Dr. Smith will talk a little bit about what you need to know as a pediatrician in terms of screening and thinking about treatment and some of the good stuff and maybe some of the less good stuff, so that when families come in and they give you everything that they've read on the internet, that you can help them navigate some of that. So first, we've got our objectives here to recognize some of those early signs of ASD, understand some of the diagnostic standards and the ADP recommendations, and some general recommendations. Really quickly, I know this is kind of small, but just I came across this, or Dr. Klein came across this yesterday in a recent neurology journal article, just a brief history of the evolution of autism and how it came to where it is today. Just to highlight the term autism, as we know it sort of came about, autism and Asperger's in 1943, 1944, in two different places. People started describing kids on the autism spectrum at the same time in two different journals. And then in the 1980s is when we started to see it actually come into the DSM. And then in 2013 was when we had our newest update where we started thinking about it as one autism spectrum as opposed to different diagnoses. So just a little mini history lesson there. So the name that we use now is autism spectrum disorder, one diagnosis. You'll still hear people use all the other terms, Asperger's, ADD, NOS, high-functioning autism, all kinds of different things. The reason why we call it autism spectrum disorder is because there's so many other terms and it's very confusing, and it's just, I think, easier to give it one term and then to describe it more qualitatively. And one of the biggest reasons they changed that with the new DSM is because there was not good reliability for why people used different diagnoses. So the biggest determination of what diagnosis somebody got was what clinic they went to. That was what the research was showing. So if you wanted to see whether your child had autism or Asperger's or nothing at all, if you went to Akron Children's versus going to Cleveland Clinic versus going to, CHOP, that was what they found was the biggest predictor of what diagnosis you got, not what your symptoms were. So some places just use autism. Some people use autism versus Asperger's. Some people love PDD-NOS. So it really didn't make sense to use these different diagnoses if we weren't using them reliably as clinicians. So we have one diagnosis, it's an umbrella spectrum, and then we think about severity, we think about verbal ability, cognitive functioning. We have all these specifiers here now so that we can really describe it as best we can. And so it's just, I think it's a better representation of what the behavioral and clinical presentation is versus just using different names. Still now, I just read, it was like Dear Abby or something like that. Somebody made a comment that was like, oh, so-and-so might have something called Asperger's. It's a high-functioning form of autism. And I was like, brah! Number one, that doesn't exist anymore. Number two, Asperger's is not high-functioning autism. It never was. There are kids with Asperger's who are way, way severely impaired. But people thought of it as high-functioning autism. There's no such thing. Anyway, so one diagnosis makes it so much easier. DSM-4 versus DSM-5, really thinking about spectrum, so it's a spectrum versus categories. And the DSM-5 eliminated rats and childhood disintegrative disorder and created this new diagnosis called social communication disorder, which we're not really going to talk about today. We don't really know a lot about it, and I actually went to a conference recently where the people who created that diagnosis were arguing about what it even is and what the specifiers were, so it's still a work in progress. One of the biggest things that's new to DSM-5 criteria is they added in the sensory piece. So previously there was no mention of sensory functioning or dysfunction in the autism spectrum criteria, and now that's part of it. And the other interesting or maybe more helpful piece is we now identify where on the spectrum somebody is. by how severe their symptoms are, thinking about how much support they need. So their severity level is defined by how much support or intervention they need. And then we have these qualifiers for with or without language impairment, with or without cognitive impairment, so we can, again, be as descriptive as possible. So this is just a reminder of what the DSM-IV criteria were for autism or autistic disorder, as it was called. There was really actually no autism in DSM-IV, it was autistic disorder. So you had, we had this impairment in social interaction, which was criterion A, and then you had impairment in communication, and then criterion C was this restricted and repetitive pattern of behavior. So as you can see, there's nothing in here that's sensory related. It's restricted behaviors, need for routine, stereotype behavior, focused interests, things like that. But what they found is, if you look at social interaction communication, there's a lot of overlap there. And communication, as I always talk about with families, communication and language are different, but there's also a lot of overlap there. So what we did in the DSM-5 is we collapsed criterion A and B into one. So now it's social communication and social interaction. And I think part of that is also to help define, we're not talking about language impairment, although that is something that we've looked at, but we're talking about communication impairment, social communication impairment. So if you have a language delay, you might be on the autism spectrum, but that is not the defining characteristic. So we're looking at deficits in social communication, social interaction, and then we still have those restricted or repetitive behaviors with that added piece of the sensory. You might either be overly sensitive to sensory information, or you might be sensory seeking. So it can be either, they call it hypo or hypersensitive to sensory information. It has to be present in early childhood, but it might not fully manifest until later on. So some kids, especially the higher functioning kids, might be able to like hang in there and mask some of the impairment until they get into school. They're pretty good at like watching and figuring things out, and then all of a sudden they get into elementary school and they fall apart. So even though we try to really diagnose it as early as possible, you might see a kid who looks not so bad at 2 or 3, and then all of a sudden at 5 or 6 they're falling apart. So it has to be present in early childhood, but just because we said things are okay in early childhood doesn't mean we can't make a diagnosis later on. They have to impair the everyday functioning. So these are the actual criteria. You have to meet both criteria A and criteria B. I'm sorry, meet all of criteria A and at least 2 of criteria B. So the stereotyped behaviors, you can have some sensory sensitivities. That can't be it. Can't be it. Someone comes in and they love to, something sensory. They love to watch fan spin. They love to rub everything. They're really scared of loud noises. That is not enough. You should put up your red flag, but that is not enough, and that's a big thing for parents. Oh man, they have so many sensory sensitivities. That's fine, but we see that in a lot of other childhood disorders too. So it's necessary, but not, or it can be part of the necessary package, but it's not sufficient. Criterion A is necessary, all of those. You have to hit all of those. Deficits in social emotional reciprocity, nonverbal communication, eye contact, body language, understanding how those things work in themselves and other people, and developing and maintaining relationships. The thing that's not in here but is vital is beyond those with caregivers. So they might do really well with their parents, but they do very poorly with other people. You have a special relationship with your caregivers, your parents, grandparents, whoever's taking care of you. So you might look pretty good, be really cuddly and make good eye contact and everything's good with them. But if you can't do that with anybody else, it's a problem. You might want to play with your mom, and you cannot play with the kids next door or with the pediatrician or anybody else who can't generalize those skills, then it's a problem. Does that make sense? Any questions so far? This is a lot of information. I don't expect you to read through all of these, but just to show you what the level of support is, there's 3 levels: requiring support, requiring substantial support, and requiring very substantial support. And again, what we're thinking of is how much intervention or support someone needs to function in their everyday environment. It's not thinking about their language delays, okay? It's thinking about their overall functioning. We're talking about language can be part of that, but it's not just language. It's thinking about their social communication. How much do we need to do? How much intervention needs to happen for this child to be able to move through their day? How much do we have to do to prevent them from engaging in some of these restricted interests and repetitive behaviors? If they have to stop at every single light switch, everywhere you go, that's going to mean they need a higher level of support than some kid who just really likes to talk about dinosaurs all the time. Both kids that we've seen here. So requiring support is the highest level, highest functioning level, someone who maybe needs a little help here and there. Requiring substantial support is someone who's going to need more team approach. There's some definite challenges in terms of their social communication, or they have more of those restricted and repetitive behaviors that are preventing them from sitting down at the table and doing their homework, or preventing them from going to baseball practice and interacting with the other kids. And then the level 3 is some of those more really classically significantly impaired kiddos who probably need the highest level of support and are going to continue to need that highest level of support. So the goal is, when we talk with families about identifying where they are at any one given point in time, it doesn't mean they can't change where they are over time, but this is just to help folks know, okay, who's the child that's going to walk into my office right now, or who's the child I'm going to be working with at school right now. So it's an important qualifier. And again, it's not just where their language skills are. If they're not talking, they're not automatically a level 3. This is just some data looking at the prevalence level. I think everyone hopefully is pretty aware. We're at 1 in 68 right now. I think the 2014 data is the same. We don't have the new pretty table for that. But you can see the prevalence numbers have really changed over time pretty dramatically since they started keeping track and putting out these numbers in 2001 and 1. From your perspective, some of the things you really need to be thinking about when someone comes in and either says, I think my child might have autism, or you're thinking in your office, oh, I think this kid might be on the spectrum, are some of the other things that might be going on. Thinking about more global developmental delays or intellectual disability, speech and language impairments, whether this child is just extremely shy or might even have selective mutism, hearing or visual impairment, that's oftentimes the things that may bring the child into your office. I think he might be deaf. I think he might have hearing problems. He is not responding when we call his name. We were at the parade and there were some really loud noises and he did not even bat an eye. That is a lot of how people start this journey, is they think there's something wrong with their child's hearing. It turns out it's fine, they just are not socially responsive. But we need to check those things to make sure that that's not an issue. ADHD and anxiety, which Dr. Smith is going to talk about in a little while. Doesn't mean you can't have these things in comorbidity with autism spectrum, but we also have to make sure that we look at these things as separate entities and make sure that if you are considering a diagnosis of one or the other, that there's enough information to say both things exist. Or you're a pediatrician and you're in an office with a white coat and this kid doesn't want to play with you. It might be because you're a pediatrician in an office with a white coat and they really don't want to be in a doctor's office. They're scared they're going to get a shot, or they don't like being at the doctor's office. So you also have to keep that in mind. The interaction you're having with the child might also not be typical because they're in an unfamiliar, scary environment. This is just a little bit of information kind of thinking about different areas of development and what we see in different diagnoses, autism or global delays and hearing loss. And so you can see that there's a lot of overlap, and we don't have to tell you that. There's a lot of overlap when it comes to developmental disabilities, when it comes to diagnoses, when it comes to different presentations in early childhood. And I think that's what makes it confusing for families. They come in and they say, my child is spinning around in circles, I think he has autism. And you look at the child and you're like, oh, I don't think this kid has autism, he's really social. How do you explain that to the family? I mean, usually the way I explain it is something like this. There's so much overlap between different diagnoses in childhood, we have to figure out what pieces fit and what pieces don't. So language delay, you're going to potentially see in autism, you're going to potentially see that in intellectual disability, and you're going to see that in hearing loss. So if someone comes in and says, my child's language is delayed, or you figure that out in your assessment, now you have some differentials, but it doesn't give you an exact path to go down necessarily. So all of these things are things to think about, but they're not necessarily going to give you one answer. This is some information on what we know right now about cognitive ability, or estimated information about cognitive ability in children on the autism spectrum. These are the same folks that are giving us the prevalence data. The way they do it is by looking at or monitoring folks in different states. So you can see some of the cognitive data is different depending on the state. Take that as you will. But there's definitely some variability there. I would say, my personal opinion is there's probably some underestimates here. It's hard to assess a lot of kids on the autism spectrum and see what their true cognitive capabilities are. So I would like to think that some of these numbers, especially these numbers, the intellectual disability numbers, are probably artificially high, but we do have to keep that in mind, that there's a good population or a good percentage of those kiddos who have comorbid intellectual disabilities, so we always have to be thinking about that piece as well. Why is it important? Why do we put so much emphasis on autism, other than it being the hot button topic that the media picks up on? It's expensive. It is very expensive to be a parent or a hospital that is providing services for a child on the autism spectrum, and more so than a lot of other disabilities. So this is just a little information on what it's like to pay for services for a child on the autism spectrum, especially because insurance doesn't cover a lot of autism-related services. And it's a lot greater than for those without autism, so $10,000 a year in 2005 versus $1,000 for those not on the autism spectrum. I think Ohio was like, recently they passed an autism insurance reform. They were like state number 48 to do it, or 46, so go Ohio. It really sucks for families, and you'll find that depending on the insurance company, they might do better if they don't have a diagnosis versus if they do. I had a family a few years ago, a 4 or 5-year-old child who was completely nonverbal, autism severity level 3, and the insurance company refused to provide speech and language therapy because they said autism is not a language disorder. And this child really, really needed language therapy, and it was incredibly frustrating. So, you know, what are you supposed to do? What are you supposed to tell that family? I mean, we definitely thought that, but autism is a communication disorder, and speech and language therapy treats communication disorders. So how can insurance say no to a 4-year-old who has no language whatsoever? I don't know. I'm still trying to figure it out. There are a lot of risk factors. We're still, as a community, trying to figure this piece out. We know there's a lot more males being diagnosed with females, although we don't know as much about autism in girls. We know there's maybe a little bit of a different presentation. Birth order seems to have something to do with it. If you have a sibling on the autism spectrum, there's an increased likelihood that, or if you have a child on the autism spectrum, increased likelihood that you will have another child on the autism spectrum, or just a general family history. Having prenatal or postnatal complications, I should say postnatal, my apologies, and extremely low birth weight, something about summer births, and multiple births. So some different risk factors, some that probably have a little bit more weight to them than others, and there's probably more things that we're still trying to figure out. Again, thinking about what do you need to know when folks are coming into your office, especially in that first year of life when you're seeing families and seeing kids the most. Reduced attention to face and eyes, so not just eye contact, but where are they looking when they are, looking around. Limited response to name, not as much showing of things. Hey, look at this. Everybody see this? Cool. If you've got toys out, what are they doing with that? Are they wanting to see, do they want to get your attention? I always tell families when I interview them, for me, the sign of a good interview is if I'm having trouble getting through everything because the kid is interfering. I put out some toys and let the kid play and I'm talking to the parents, and if that kid is interfering with my ability to talk to the parents, that's a good thing because they want my attention, they want to play with me. That means they're sharing enjoyment and they're trying to get my attention. If I spend an hour with the parents and the kid doesn't even know I'm in the room and we have a great hour-long talk, then I'm concerned because the kid just didn't interact with me at all. And I'm kind of fun. That's why I do what I do. So I try to make it fun. I want them to come up and play with me. Pointing is a big one, not just for this is what I want, but look at that. Everybody, look at that over there. We want to see a lot of that. Obviously, maybe not with the look at that over there, but how do they get your attention? How do they show you what they want? Reciprocal babbling, so even if they don't have language, you can still have a conversation with someone. Child starts to babble, oh really, tell me more about that, and see, do you still have that back and forth. Kennedy Krieger has a nice little one-page little handout, characteristics by age. If you're interested, you can Google this or you can get it off of the presentation, just looking at some of the things you want to be keeping an eye on that can be seen between 6 and 12 months and then 12 to 30 months when it comes to social interaction, communication, play, and sensory and motor. So that may be helpful for you. When can we make a diagnosis? I've had families come in and say, well, I've been concerned since 1, but the pediatrician told me, or the school told me I couldn't come here until he was 8. No, that's wrong. 2 is usually kind of what we in the community say is about the age where we feel really comfortable with making a diagnosis that we can feel good about and that's pretty reliable. But usually by age 1, we can see some red flags. They've done some studies. They've looked at children's first birthday party videos, and they've been like, yeah, we saw some signs even back then. Even if the parents weren't concerned, they'll code them and they'll see, yeah, this kid wasn't really paying as much attention to the other kids, their eye contact wasn't great, so they can see even some of those signs. That's why it's so important for you to be really keeping that in your mind. They're doing research now on eye contact and eye shift on 2 to 6 months olds who are at risk. They have siblings on the autism spectrum, and they're seeing differences in what their eye gaze looks like, and following them and seeing that that's starting to be a predictor of diagnosis later in life. So if you see a child, it's not too early to have a conversation at that, as Dr. Smith will say, at that 18-month or 2-year appointment when you're doing your autism screenings. We do have a subset of the population that is doing pretty well, and then you see a regression. Usually it's somewhere between this 19 to 21 month period. Clinically, I would say about 18 months to 2 years is what families typically report. They were talking, but they had maybe about 5 words in a year, and then it just sort of went away. They stopped talking, it's like the light faded or the light just turned off, and they stopped. He was really social, good eye contact, and then it sort of went away. So it's those language and social skills, and then they start to see more of this typical autism progression. So keep an eye on that keep an eye out for that as well. So before I talk about assessment, I know I'm going kind of fast, so we have a lot of things to go through. Any questions about what it looks like? Okay, so you're all ready to go. Good. So we know kind of what it looks like, how do we assess for it? So most evaluations are going to include, or should include, thorough parent interview, qualitative observation, some sort of standard or semi-standardized testing. Most evaluations are going to include the ADOS, Autism Diagnostic Observation Schedule. It's a semi-structured, play-based assessment. It is considered the gold standard. It is not the only thing to do, and it is not the end-all be-all of autism assessments. It was actually not designed to be a clinical instrument. It was designed as a research tool just to standardize clinical observation. But it's really helpful because it is a way to be consistent across providers, and it's fun for the kids. You put out toys and you play, and then we as providers or assessors watch and take tons of notes, and then the scores are based on our behavioral experiences. So it's a behavioral observation with structured scoring protocols. So we can use it with kids with a nonverbal mental age of at least 15 months, and we adjust what we do with the kids based on their age and their language level. So with the younger kids, we blow bubbles, we blow up balloons, we play with toys, we read a book, we ask them how to brush their teeth, we give them a snack, and all of those things are designed to pull for all the skills that we've just talked about. So we blow up a balloon, and then we hold it up like this. We see what they're going to do with it. They're going to point to it. They're going to ask for more. They're going to try to grab it. They're going to walk away from us. They're going to jump up and down, flap their hands. So all we have to do with a balloon is just stand there with it. And then we go, 1, 2, 3, and we let it go. And then we see what happens. Most of them go like this. And then they run for it. And then we have to run after them because we don't want them to put it in their mouth. But then what do? Do they hand it to us? Do they ask for more? More. Do they look at us when they're giving it to us? Do they wander off because they're not so interested? Do they try to run out of the room? They flick the lights on enough? All of that information out of one balloon. It's pretty cool. So all of these things are designed for that. We get a lot of good information from that. For the older kids, it tends to be more conversation. We put out action figures to play with, maybe instead of a balloon. We'll ask them what it means to be a friend, what does it feel like when you're sad, what can you do if you're feeling lonely, so we can understand their insight into those things. And then we also just think qualitatively, how did this go? Does it feel super awkward when we sat there? Were there long silences? Was it sustained conversation? Did it feel spontaneous? Did I walk out of there feeling extremely drained? Did I walk out of there being like, man, that kid was fun, I'll take him home? And that gives us qualitative information too. We're looking for repetitive use of objects. How do they use objects in a functional way or non-functional way? We have string that we put out. We have a textured block to see what they do. I had a child once who spent 10 minutes with this glob of string went like this. That gave us some really good information. And he was perfectly happy. We had all kinds of other toys out. Sweetest little boy. But that's what he wanted to play with for 10 minutes. How do they use their language? These are examples of things we've had kids say. Instead of I have to go to the bathroom, well, I have to empty my bladder. Kind of an unusual way to say that, right? So that tells us like their language is, they have language, but it's kind of, that's that idiosyncratic language. It's a little bit weird. That's not how most people tell us they have to go to the bathroom. This little boy, Simon doesn't poop in the potty. He said that like 20 times. It wasn't really 8 or 9. He's talking about himself. He doesn't realize he should say I, because people are calling him Simon, so he's calling himself Simon. So those kinds of things. We had a child once who was so into dinosaurs, we could not give him a prize for being done with testing because we didn't have any dinosaur stuff. So he did not want anything because it wasn't dinosaurs. He was done with us. We couldn't even pretend. We had some bouncy balls. Hey, this looks like a dinosaur egg. That's not a dinosaur egg. And he was done. Scoring is subjective. Higher scores mean more impairment. But the most important thing is just because you have high scores doesn't mean the child has autism. It means there's some concern there. But you have to take all the other information you've gathered. So if someone were to bring you, let's say they just brought you a protocol and said, oh, my child had an ADOS, so what do we do with this? Does he have autism? You can look at it, and you can say, okay, well, maybe there's some concern here, but you can't just go, oh, his score was a 10, cut off for autism's an 8, yep, he's got autism. You have to take everything else into account, because there's other things that can factor into the scores. You have to do that. We've had kids who are so ADHD that they can't participate, so they get high scores because they're not interactive. But they have good social skills, those little tiny moments when you've got them for like half a second, and you know those kids because you've seen them in your office. They're really good, but then you can't keep them. It's 30 seconds later, they're bouncing off the walls. So they can't show what they're capable of. Okay. So I'm going to really quickly show you a couple of examples of 2 kids, one who's 6 years old and one who's 3 years old, but they both show you the same activity. So you can just get a sense of a little bit of what we do during the ADOS. This is the first one. She's 6 years. Going to kindergarten via online school, that's a whole different issue, I'm not going to talk about it. Couldn't get any interpretable scores, you'll see why. She was diagnosed with autism, a language disorder, and she also has some separation anxiety disorder, although there's some, it goes both ways. So the first thing I'm going to show you is just an example of what it was like when we tried to transition away from the free play toys. And you've probably seen sorry, the volume's not coming through. So we were just putting away a truck and some blocks. She's 7 or 6. So we might expect some happiness.
Some different toys. Nobody gets different ones, okay? It's okay.
This happened every time we transitioned between any 2 activities the entire day. In and out of the room, to and from the bathroom. This is
How would she access the new activity?
That's a really good question. Let's find out. I'm going to skip ahead because it's a few more minutes before she does. We had to bring new things and play and just sort of let her get into it. That was part of why they were here. It's like, how do we get her to do this? You know, parents were not really helping the situation. I know you guys see that a lot as well. Let me get to it. This is a new transition. God bless our psychiatrist who do this testing, right? And I know you guys see this in your office. So this is some free play. Or not free play. This is where she's going to take out some dolls.
Hang on, I'll get it for you in a second.
And see what she does with them. So we're looking at creativity, imagination, we're looking at shared play.
And there's a little baby.
So eventually we give her something else and she can kind of focus her
And
attention.
then here's some of their things. Okay, I'm going to take out all these things. Alright. And then when we're done playing, we're going to put them away and do something else.
So she's already giving her warning.
And it'll be
We are going to put
okay.
these away and we are going to do something else. So, Elena, who's our psychiatrist, she's warning herself what's going to be best.
Here's a fire truck, yeah? Here's this little thing. I don't know what you do with that.
So what she's doing is she's labeling everything. Airplane, fire truck. She has pretty good language, but most of it is echolalia. So she either will repeat what she hears or she's just kind of labeling things. She doesn't really do too much with the objects. Most of the kids are going to grab, oh, this is the mommy making the baby. You know, kind of start to put together some kind of creativity. Remember, she's almost 7, so we're expecting some pretty good creativity from her, being almost 7. And she's just kind of looking at things. She does eventually, you know, she asks what some of these things are. She does fly the airplane. I'm going to kind of go a little fast just for time's sake. But there's just not a lot of, there's not a lot to it. But she does get quiet. So that's kind of nice. Until we transition away from it. But she's got in her lap, there's a little shiny disc, so a lot of kids will just spin the disc over and over and over. That's why it's there. So really, really quickly, I'm going to show you, this is a 3-year-old who's had no intervention. She's got some pretty significant language delays. Doing the same thing.
Oh no, Junior upset the baby!
And they're playing with the toys.
Over here in the
He brought
crib.
the truck in. He wanted to play with the truck
There we
too, because
go.
he's been playing with the truck.
There we go. Now baby goes to sleep.
And he's sat in this meeting.
Alright.
Oh, let me back up, I'm sorry. I didn't see that, did I?
What? Don't push going back.
He's got some good practice, it's really hard to understand. But he immediately starts setting up this scene where the driver of the truck is chasing the dog.
That dog doesn't like the dump truck, does it? No.
And he's allowing Cameron to interact with him. And he's like talking through the scene. Again, he's really hard to understand.
What is the dump truck driver doing?
I don't know. It's one away from the doggy.
Oh, he's running away? He got scared of the
So
dog,
he's
huh?
only 3 and he's already like creating this
He's
more
really
creative scene.
What?
Much more interactive. Later on, I'm not going to show too much of it, but later on Cameron like brings it in, as we saw, and they start laughing and they're like giggling with each other, and it's this much more
This doggy
shared
sister
experience.
and
He, at the end, when she's like, it's time to clean up, he's like, okay, he puts everything back in, so that transition is much easier. Anyway, so this is a very brief little glimpse of the kinds of things we do. So we get to play with toys, and that tells us a little bit about that autism. He did not get a diagnosis of autism, by the way, but she did. We knew before we even, like, we met her in the waiting room, and we're like, all right, you've got autism. We didn't need to do an ATOS, but we did it anyway. So, any questions about assessment? Okay, thank you.
Thank you.
Sorry.
So I'm Dan Smith. I'm the Developmental Behavioral Pediatrics Fellow. I want to apologize ahead of time if there's some sniffling or coughing or scratchy throat. My allergies have been beating the crap out of me this week. I want to talk a little bit about what we know about the etiology of autism. I'm going to go into some of what your role as a pediatrician is going to be and some of the treatment modalities. As far as a cause, we don't know. There's no known single cause of autism. We know that genetics probably has the largest role in this. We know that it's more common in boys, 4.5 times more common in boys, something about that Y chromosome, I guess. The twin studies have shown, like it says in there, 60 to 90% concordance rate amongst identical twins, and a 0 to 10% rate amongst fraternal twins. I couldn't find the exact source, but I believe the largest kind of study to date looking at siblings and concordance rates came out of, I think, Denmark a couple of years ago. In Denmark, they tracked pretty much every child born, and that showed a 7% concordance rate amongst siblings. So 7% is the best number that we have to date amongst that, which is higher than the 1 in 60 in the general population. Below that's a list of some specific chromosomes. These are chromosomal deletions, duplications, translocations, and some of the genes that are on those specific chromosomes that so far have been identified to have an association with autism. And the terminology association is important. They haven't been identified as a cause, they're associated. So in children that have autism, some of these have been identified. But these specific gene defects have been identified in people that don't have autism. And so that's why there's still, like everything else, there's overlap with this. And we haven't been able to pinpoint any one thing. We do know through imaging and, there is neuroanatomy differences between children with autism, between typically developing children. The idea of impaired, what's called cortical pruning, is a large factor in this. So children with autism have many more synapses and different ratios of brain matter than typically developing children. So think about, if you will, a home theater system. You have a TV, you have your cable box or Roku, you have your speakers, you have 5 or 6 cables that plug into each other in a specific order. Everything works the way that it's supposed to. Think about someone taking 200 cords, wadding them up in a ball, throwing it behind the TV and saying, plug things in where they're supposed to go. That's kind of an oversimplification, but it's a good way to think about how impaired cortical pruning can affect this child's brain. The synapses don't go where they're supposed to, and so you just see glimpses of things come about working in a way that's different than what we would expect. The next kind of line of research into this is, okay, we have these identified genetic predispositions or associations. What about those sets things off? And the next thing is looking into environmental factors. Is there something, kind of a second hit hypothesis, something that happens during the prenatal development that someone has this genetic change, something in the environment occurs and then causes this gene that's defective to be expressed as autism. There's still, a lot to be learned about all of this. One thing that I didn't even include on the slide of etiology, out of respect for everyone, because everyone should know this by now, and if you don't, you should come talk to us because we'll set you straight. Vaccines do not cause autism. We all know this. Parents still don't know this. Some do, some don't. And I usually take a little bit of time and explain kind of the origin of where the whole idea of vaccines and autism came from. So Andrew Wakefield was a GI doc in Great Britain. In 97 or 98, he published a study that linked autism to the MMR vaccines. And more specifically, it got into thimerosal, which is a mercury preservative. Thimerosal has never been used in the MMR vaccines. Thimerosal contains ethyl mercury, which is a mercury compound that is metabolized and excreted from the body much quicker than methyl mercury, which is the toxic mercury in fish and thermometers and things like that. From 99 to 2001, all the thimerosal was removed from the vaccines except for some flu and some HIP. Despite removing thimerosal from all these, the rates of autism didn't decrease. And people started, and no other studies were repeating these findings. So people are like, okay, what's this? What's the first paper? In 2004, a British journalists investigated kind of into this and found a whole bunch of undisclosed financial conflicts of interest from Andrew Wakefield, and then co-authors started to pull back their support from the paper. Then the General British Medical Council or Committee started looking into this, and in 2010 kind of concluded their findings. And there were dozens of charges that they kind of found upon him, including multiple counts of dishonesty and fraudulence and abuse of children with developmental disabilities, including unnecessary colonoscopies, unnecessary lumbar punctures, and operating outside of the ethical approval of an institutional review board. And no other studies have showed these findings. So, you know, if you share that with the families, it helps. Moral of the story is don't make stuff up with your research.
He lost his medical license.
Yeah, he's barred from practicing medicine in the UK now. You can also show families this. This is the JennyMcCarthyBodyCount.com. Right, so this is from 2007 to 15, so these numbers are still 2 years old. 150,000 preventable illnesses and almost 10,000 preventable deaths. And that's in an 8-year period. So, as a pediatrician, what's your job going to be? You're not going to be managing all of these specific things, but you are going to see children with autism that have all of these issues. Sometimes you are going to be managing some of these things. From the time you start to have concerns about this and make a referral to us, it can be 6 to 12 months before they get in to see us. Sometimes we make the diagnosis right away. Sometimes we need to do extra steps like refer for anything else. So you're going to see some of these issues. We don't have time to go through each specific one, but recognize that more children with autism are going to have problems with some of these, and they're going to be more difficult to manage. I'll share with you towards the end some of the resources that I provide to parents that can help with some of these issues. In my opinion, one of the most important things that you can do as a pediatrician is recognize the signs of autism and identify when further evaluation needs to be done. You don't necessarily need to be making the diagnosis, but you need to learn how to recognize it and screen for it. So the MCHAT is a screening tool, and it's recommended by the American Academy of Pediatrics to use an autism-specific screening tool at 18 to 24-month well-child visits. The MCHAT is the most widely used of these. It's 20 questions, yes or no. You can use it from 16 to 30 months, but like I said, you want to use it at the 18 to 24-month well-childs. This is what it looks like, 20 questions, yes or no. Yeah, I'm missing some slides. So I apologize for the missing slides. I had some in here about the scoring of it. So for the scoring, slides 2, 5, and 12 are opposite scored. A score of 0, 1, or 2 means that there is no concern. You don't have to refer. You can, if they're under 24 months, screen at their 24-month visit. Scores of 3 to 7, you need to do the MCHAT follow-up questionnaire. Okay? And that a lot of times is what's missed over. If someone has a score of 3 or above, a lot of times we just get referred. The majority of kids that score 3 to 7, if you do the subsequent follow-up questionnaire, actually will not be need to be sent in for referral. The follow-up, and then a score of 8 or above, you can refer without doing the follow-up. The follow-up questionnaire consists of the same questions of the original one, but they are relabeled as pass and fail. With each question, then there is an algorithm that goes along with it. And the algorithm looks like this. So it does take more time, and you can usually have an MA or someone go through it. But basically, you ask the question, and if they tell you yes or no, then it prompts another question. And you kind of go through this tree until you determine if it's pass or fail for that specific question. If after you do this, again, there are 3 or more fail, then you can make the referral. If there are less than 3, then you're okay to just re-screen again when they turn 24 months. Some of the other things you'll be looking at, or that you'll be seeing, ADHD, other behavioral concerns, mood disorders. The DSM-4 did not allow for someone to have a diagnosis of autism spectrum disorder and attention deficit hyperactivity disorder, but the people that worked with children with autism knew that you could have both. In the DSM-5, they allowed us to make both of those diagnoses at the same time. You're going to see anxiety, depression, those types of things. And it can be more difficult to identify in these children, well, because they can't communicate the way that, a typically developing child can. And things like anxiety and depression can be difficult for a typically developing 11-year-old to talk to you about, let alone someone that has language delays or communication problems. So a lot of this, we're kind of going off a lot of externalizing symptoms. The other thing that's really important to know as a pediatrician is what types of services are available in your community for these families. If you're gonna, after you graduate, you're gonna go out to another community to practice, one of the first things you should do is figure out what's in your area that you can send kids to. We have a large referral database here. We get kids from 2.5 hours away. So I still am Googling services almost, every day I see patients, I'm Googling what's in the area. So it's important to know that stuff. As far as treatment options, there are a lot of treatment options out there. Medications are something that we think about. With all the different treatment options and supports, it's important to remember that there's not one treatment option for a child with autism. There's not one thing that fixes everything. The treatment for a patient with autism is going to be geared towards the individual needs of that patient and their family. While all kids with autism need some sort of support, some level of support, not all children with autism are going to be on a medication, but more of them are than the developing population. You might not be writing for these as a pediatrician, but your patients are going to be on some of these, so it's important to know what's out there, what's available. And again, we're treating the individual needs of the patient, so the different comorbidities. Aggression, irritability is a lot, we see that a lot. The atypical antipsychotics are what we use for that. Risperidone and aripiprazole are the two FDA-approved medications for aggression and irritability associated with autism spectrum disorder. They're the only two medications that have an autism-specific indication. Some of the anti-epileptics or mood stabilizers are also used, Keppra, Depakote, Topamax. ADHD, like I said, we're going to treat that like ADHD. Methylphenidate, I believe, has the largest background of research in autism, but it's the same kind of trial and error with ADHD management as it is in the general population. Sometimes it'll be a little bit more difficult because it can be harder to get these patients to swallow pills. Anxiety, depression, and mood disorders, we're going to use SSRIs or Buspar for these. With it, the SSRIs, fluoxetine and fluvoxamine, so Prozac and Luvox are the two that have randomized controlled trials specifically for autism. Again, not an autism-specific indication, but there's more research with those. Sleep disturbance. The first line of treatment for sleep disturbance is behavioral modification. Looking at the environment, looking at their sleep hygiene habits, making sure the screens are turned off 30 to 60 minutes before bedtime, making sure there's no TV in the room, that they have a good routine. That's before doing any medications. That should be first line across the board. Then we can use melatonin, some of the alpha agonists, clonidine or 10X, mirtazapine, which is Remeron. Trazodone is another option that I didn't list in here. Kind of like I said before, not one thing has been shown to be best. Overall, you want to get things going as early as possible. No one's ever going to fault you for making a referral to Help Me Grow for kids that are under 3. Kids that are over 3. No one's ever going to fault you for telling a parent to go get evaluated for enrollment in a developmental preschool or to go see speech therapy. If you're making a referral to developmental peds for an evaluation of autism, you should simultaneously be making a referral to Help Me Grow if they're not involved, or to a developmental preschool if they're older than 3 and not already enrolled. Programs need to be intense. There needs to be a low student-to-teacher ratio. They need to be highly qualified or trained individuals doing this. There should be a lot of parental involvement as well. These are the National Academy of Science recommendations, kind of the same thing. Start interventions early, within 60 days of identification. identify the strengths of the individual and try and build programs that use those strengths of the individual to build on the areas that they are weaker in. Listen to your families. Listen to the parents' concerns about what they want their child to be able to do and not to do. Minimum of 20 to 25 hours a week. Kind of the same thing we were talking about already. Help Me Grow, we talked about that, that's for children under 3. Help Me Grow is the under 3 early intervention program that's in Ohio. Each county in Ohio has Help Me Grow. There is an under 3 early intervention program in every state, but they're not always called Help Me Grow. They have, different names, but the fundamentals are the same. The Help Me Grow interventions are focused on teaching the parent what things can be done in the home to help the child develop over time. Once they get into school, then they're going to, if they qualify, it would be for an individual education program or an IEP. This is focused more on how their impairments relate to their academic skills. So you can get speech therapy, occupational therapy, physical therapy, in the school setting to address impairments in those areas related to academic functioning. So sometimes kids might need additional speech OT or PT outside of the school. The Board of Developmental Disabilities should be available in all the counties as well, and there are other supplemental programs, which again is important to know where you're going to be working, what is available in your community. There are, as far as behavioral interventions, there are 2 kind of models of treatment. Both have evidence behind them. On one end of the spectrum is what's called, the most popular one's ABA. On the other end of the spectrum is kind of floor-time responsive teaching modeling. ABA is more goal-driven, very intense one-on-one, using kind of an operant conditioning model to kind of condition responses in the child using behavioral motivators and reinforcers. Whereas the responsive teaching model is much more child-focused, it's getting on the child's level, really encouraging reciprocal interactions and communications as a way to help them kind of grow and develop. There's evidence behind both of them, not necessarily that one's better than the other. We do tend to favor the responsive teaching floor-time model in the younger children. The Play Project for Connections program through FCLC uses that.
Oh, the camera might have timed out because sometimes if it's been on a long time, it'll shut
Turn it
down.
back on.
It won't come right back up, Dan. Yeah, sorry.
You know why? Because we were gonna talk about complementary and alternative medicine. It does not like
That's
that.
right. It doesn't.
No, sir.
Which means I can't show you some of the other research. Well, we'll see when it comes back on. So CAMs are complementary and alternative medications. It's important to know about these. Hopefully you're not doing a whole lot of recommending these to families, but a lot of families are going to be using these. The research has really shown about 50% of families that have a child with autism spectrum have used or are using a complementary alternative medicine at one point or another, which is much higher than the general population. If you think about this from a parent perspective, most of the parents that we work with, they don't have the knowledge base that we do, they don't have the education we do. They have a child with autism, they can't interact with or communicate, so they're going to do whatever they can to help their child. There are a lot of people out there that will take advantage of that, and so it's our job to be able to kind of point parents in the direction of, okay, what can you do that's benign? What is out there that is going to be harmful? So things like heavy metal chelation, hyperbaric oxygen therapy, raw camel milk baths, clay baths, things like that. They're all out there, and there are someone that will charge a parent $1,000 to do this thing that it cures autism, whatever. You want to be, in general with CAMs, you want to let parents know to be cautious with anything that promises to treat. If it promises to treat or cure anything, one, you need to be wary of that. If it talks about curing multiple illnesses, you need to be wary of that. If it promises a quick fix, you need to be wary of that. If there's no evidence to support it, you need to be wary of that. So there's a lot of things to review with families. The FDA just put out an updated statement. Beware of potentially dangerous therapies and products. It's nice to have those FDA statements out there because it lends further support to us telling families to be aware of this. It also provides us updates on what new things are out there. I didn't know about the raw camel milk or the clay baths until I read that FDA update. So it's important to look at those types of things. And we still don't have it back on. So some of the resources, I had the websites up. Some of the resources I point families to are autismspeaks.org. On that website, there are toolkits on the top right-hand corner that are free for families. They download as a PDF. They cover a wide range of things such as toilet training issues, constipation issues, difficulty with feeding behaviors, going to the dentist, having blood draws, medication decision making. There are a lot of things on there that are free for families. Ocali.org is another good website. OCALI, Ohio Center for Autism and Low Incidence, national organization based here in Ohio. On there are autism internet modules that are free for families. They take 10 to 30 minutes, cover a wide variety of topics. They're free. Parents live in Ohio. There's a lending library at Ocali where they can get books sent to them, again, for free. The Autism Society of Greater Akron is based here in Akron. It's another good advocacy resource for families. And in the sheet, there are other resources for the pediatrician to use. When you work with us, we go through some of the CDC case training modules that talk about early signs of autism. I'm not sure how we're going to do the questions, but I think Dr. Coon's going to take care of that, and then we'll open up for questions to us. And if we run out of time, come find us afterwards.
So I will read these to you. I was going to anyway, but I'll keep.
They're on the handouts also,
Oh,
so
okay.
everybody got the
There are
handouts.
handouts.
Yes,
Table that can be
Please, read
utilized.
the handouts.
they're spread around, so.
All right, so we have an 18-month-old boy is brought to your office by his mother who tells you she is concerned about his speech. He cooed and babbled until 9 months of age, but does not use or repeat any words. He does not turn his head when his name is called or make eye contact when spoken to. However, he makes good eye contact at other times and will point to draw the attention of his mother to things he finds interesting. He reacts when there are loud noises, such as when his mother vacuums the carpet. When given a crayon, he will scribble spontaneously. He can hold a cup. He enjoys running and throwing the ball to his parents. His favorite toys are cars and trains. Of the following, the most likely evaluation to identify the cause of this patient's developmental problems is an evaluation of his A, cognitive and adaptive skills, B, hearing, C, social emotional development, D, speech and language development, or E, vision. Anyone have any ideas? Hearing, yes, very good. And what made you think Mel would ask you that?
Yeah.
So why do you think it's hearing?
He interacts well, it looks like. With the vacuum, that always makes me think of more like vibratory sense than hearing sense.
Yeah, and what we had mentioned earlier in the lecture with, he has like good eye contact, other times he points or gets his mother and has that shared attention, so hearing is correct. All right, so correct question 2. A 2-year-old is brought to your office for a health supervision visit. The mother has brought her 4-year-old sibling, and the 2 children are playing in the corner of your examination room. We confirm that the patient has approximately 50 words, is using 2-word phrases, and half of her speech is understandable. As you are talking with her mother, you hear the 2-year-old girl cry, "No," followed by the 4-year-old sibling saying, "Ow, she bit me." Her mother cries, "Stop biting," and then turns to you to ask why her child bites. Of the following, the most likely reason for this child's behavior is A, Autism Spectrum Disorders, B, emerging behavioral disorder, C, exposure to violence at home, D, inability to adequately verbalize her frustration, or E, speech language delay. D. Exactly. Inability to adequately verbalize her frustration. So, and just the point of this was to be like, it's kind of typical for kids around that age to bite. It's part of development because they can't express themselves, and so you get more concerned about biting once they're like 3 years old, and that's more of a behavior concern. All right. And so here's the last one. You're seeing a 5-year-old boy and his adoptive parent because of educational concerns arising in kindergarten. He was adopted 1.5 years ago following a brief time in foster care. He has a history of chronic and severe neglect by his biological parents. His adoptive parent says she noted fairly quickly that he was developmentally behind, but had been told that with parental attention and stimulation he was likely to catch up. However, that has not turned out to be the case. Hearing and vision are normal for his age, but communication as assessed by his speech therapist has not progressed beyond using occasional 2-word phrases. He is very active and is quite a handful according to his mother. His attention and focus is poor, and although he does make eye contact with his parent, he avoids eye contact with others. You think it is likely that this patient has an intellectual disability and have recommended that he has been seen by a psychologist for IQ testing. Of the following, the additional information needed to confirm your suspected diagnosis is A, adaptive behavior assessment, B, ADHD rating scale, C, autism symptom rating scale, D, brain MRI, or E, the EEG.
Anyone who came to my intellectual disability lecture better not get this one wrong.
So it's,
Better not.
it's A, but I'd be concerned about even making that diagnosis in a 5-year thing.
So the answer is A. Yeah. So it's asking about, this is more about like IQ testing. Like once you do the testing, you need to prove that you can't give the diagnosis of intellectual disability if they have life skills, good life skills. So these questions are more to show like you should be thinking about autism, because some of them have red flags, like they're not making eye contact, or well, the biting, but it's more like self-biting, with autism that you may see. And then with this one, autism is a possibility that's mentioned like before eye contact, and this kid could have both. He could have autism and he could have an intellectual disability.
Any questions for us? Everyone needs to get back to work. All right, thanks for coming.